Hi friends, in this topic of general examination, today I will talk about clubbing. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel for educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. Clubbing is also called Hippocrates fingers. It is a bulbous enlargement of distal segment of the digits and subsequent loss of normal angle between the nail and the nail bed. Here we can see the angle between the normal angle between the nail and the nail bed is less than 160 degree, but in clubbing it goes beyond 180. It typically occurs in other dermatological and skeletal findings, but can also less commonly occurs in isolation. Although clubbing can present in many pathological conditions, it can be idiopathic or familial. Multiple theories have been postulated for the pathophysiology of the clubbing, but the most accepted one is the platelet derived growth factor and vascular endothelial growth factors. The initial hypothesis suggests that clubbing results from the peripheral deposition of the clumped platelets and megakaryocytes, which are otherwise sequestered by the pulmonary vasculature. The megakaryocytes, they preferably large in the tips of the digits and locally release platelet-derived growth factors and vascular endothelial growth factor. These growth factors, along with other mediators, they increase the endothelial permeability and activate and cause proliferation of the connective tissue cells, for example, fibroblasts. The release of both platelet-derived growth factor and vascular endothelial growth factor is thought to be increased by hypoxia. Another hypothesis is neurogenic. Persistent vagal stimulation causes vasodilation and clubbing, as seen in lung carcinoma. Hypoxia is another important postulated hypothesis. It causes opening of the deep arteriovenous fistula in the fingers and as seen in tetralogy of Fallot. Ferritin, prostaglandins, bradykinin, adenine nucleotides, 5-hydroxytryptamine. These circulating vasodilators are usually inactivated as blood passes through the lungs and bypass the inactivation process in patients with right to left shunts. While evaluating the nail clubbing, a proper history and physical examination are very crucial to diagnose, and the key points are when not all the patients with clubbing have underlying disease, and not all the patients with disease will show clubbing, so it can vary in severity. In physical examination, we check the lobby bone angle, which is normally less than 180 degree. More than 180 degree indicates clubbing. Hyponychial angle, it is normally less than 192 degree. Phalangeal depth ratio, normally it is less than 1, more than 1 is clubbing. Shamroth signs, that is obliteration of the diamond shaped window between the corresponding fingers. All these angles or signs I will be discussing in my next slides. So, while evaluating the patient, we should take proper history, consider the possible cause of clubbing, and then we will have to perform the physical examination, assess the nail clubbing as mentioned above. And initial workup should include routine CBC, chest X-ray. If chest X-ray is not suggestive, we must do CT scan, 2D echo, and other investigations. Let us discuss about the various ways how can we elicit the signs of clubbing. First is the Lowy bones profile sign. Here we bring the patient's fingertip at the level of our eye and we look tangentially at the onychodermal or Lowy bones angle. Normally it is less than or equal to 160 degree. In clubbing it is more than or equal to 180 degree. Second is the Kurz modified profile sign. This is uh, Lowy bones angle or profile sign, and second one is the Kurz modified profile sign. Here we can measure the angle between the middle and the distal phalanx. Normally it is less than or equal to 180 degree. In clubbing it is less than 160 degree. Sorry, normally it is 180 degree, but in clubbing it is less than 160 degree. The third is the fluctuation test. Here the patient's fingertip is placed on the pulp of examiner's two thumbs and held in this position by gentle pressure with the tip of examiner's middle finger applied on the patient's proximal interphalangeal joint. The patient's finger is then palpated over the base of the nail by the tips of examiner's index fingers, and there is increased fluctuation of the nail beds in the clubbing due to softening of the nail bed. Next is the Shamra's window test. This sign is elicited by placing the dorsal surface of the terminal phalanges on opposite fingers together. Normally, we see a diamond-shaped window, but in clubbing it is obliterated. This sign is also known as diamond sign. Next is the phalangeal depth ratio, the ratio of distal phalangeal depth to interphalangeal joint. Uh, it is measured by using caliper. We should touch the skin but not compress it. The ratio is normally less than 1, but if it is more than 1, it is suggestive of clubbing. Another is the digital index. Here we check the ratio of the circumference of the finger at the nail bed to distal interphalangeal joint, and this is calculated for all the 10 fingers and summed up. Then final value is divided by 10 and the resulting value is the digital index. If it is more than 1, it is suggestive of clubbing. It is more specific for clubbing. Coming to the grades of clubbing, grade 1 is the increased fluctuation of the nail beds. Grade 2 is the loss of lobby-bound angle or onychoechial angle, that is less than 180 degree. Normally it is less than 180 degree. If it is more than 180 degree, it is a grade 2 clubbing. We also check Shamroth signs and profile signs. If they are obliterated, Shamroth sign is obliterated or it is positive, then we uh, call it as a grade 2 clubbing. Parrot beaking, drumstick fingers, as mentioned in the figures, they are present in grade 3. They suggest the grade 3 clubbing. Drumstick figure is seen in severe cyanotic heart disease, bronchiectasis and empyema. Next is the grade 4. Here uh, pain is felt by the patient along the distal end of the long bones due to subperiosteal new bone formation, and it is seen in bronchogenic carcinoma. Grade 5 is glossy changes in the nails and adjacent skin with longitudinal striation as proposed by the Lung India Foundation. Coming to the causes of clubbing, the respiratory causes are malignancy, as in seen in bronchogenic carcinoma, mesothelioma. Second is the suppurative diseases like bronchiectasis, lung abscess, empyema, interstitial lung disease, tuberculosis. Clubbing is seen in 30% cases of tuberculosis as a sequelae to complication. In sarcoidosis, we can also see clubbing. The cardiac causes are subacute bacterial endocarditis, atrial myxoma, cyanotic heart disease, acyanotic heart disease with aspergillization. The various gastrointestinal causes are inflammatory bowel disease like ulcerative colitis, Crohn's disease, primary biliary cirrhosis, hepatocellular carcinoma. The neurological causes are syringomelia, median nerve injury, hemiplegia, and the various other miscellaneous causes are pachydermoperiostosis, that is pan-digital hereditary clubbing, Torrent-Solentin-Gall syndrome. Always remember that uh, patients of COPD, they will never show clubbing. There are certain other conditions where we find atypical clubbing, like acute clubbing. It is seen in subacute bacterial endocarditis, lung abscess, empyema. Unilateral clubbing is seen in hemiplegia, aneurysm of the subclavian artery, Pancoast tumor. Pseudoclubbing is seen in leprosy, leukemic infiltration, hyperparathyroidism, thyroid acropathy, sclerodactyly, exposure to vinyl chloride, subungual tumors or cysts. Painful clubbing is seen in bronchogenic carcinoma, subacute bacterial endocarditis, lung abscess. Reversible clubbing is seen in lung abscess, empyema. Unidigital clubbing is seen in median nerve injury, trauma. Clubbing with cyanosis is seen in cyanotic congenital heart disease, interstitial lung disease. Differential clubbing, that is, upper limbs are normal, lower limbs show clubbing, seen in patent ductus arteriosus with reversal of the shunt. Upper limb clubbing, lower limb normal, seen in patent ductus arteriosus plus transposition of the great arteries plus reversal of the shunt. While examining the nails for clubbing, we may see other nail changes also, like koilonychia. It is seen in iron deficiency anemia and hemochromatosis. Bewes lines are seen in measles, pneumonia, pulmonary infarction. Plumber's nails are seen in hyperthyroidism. Red nails are seen in congestive cardiac failure. Blue nails in copper or silver deposits. Black nails in Peutz-Jeghers syndrome, Cushing disease, Addison disease. White nails seen in anemia, hypoalbuminemia, diabetes mellitus, congestive cardiac failure, rheumatoid arthritis. Causes of clubbing can be remembered with mnemonic like clubbing with A, B, C, D, E, F, extension of L. For example, this is for bilateral clubbing. The cardiovascular causes are C for cardiovascular causes, seen in cyanotic heart disease, that is Fallot's tetralogy, subacute bacterial endocarditis, atrial myxoma, Eisenmenger syndrome. L in the clubbing stands for lungs and the pleura. A, B, C, D, E, F. Uh, A for lungs and pleura. A is for abscess, B for bronchiectasis, C for carcinomas, C for cystic fibrosis, D for don't say COPD, E for empyema F for fibrosis as seen in chronic interstitial lung disease. L in the clubbings is for the liver, that is chronic active hepatitis cirrhosis. U in the clubbing is for ulcerative colitis, B for biliary cirrhosis, I for intestinal disease like inflammatory bowel disease, celiac disease, lymphoma, carcinoma, escheriasis, amoebiasis, and N is normal, that is idiopathic. Genetic causes are pachydermoperiosteitis, a syndrome that combines hypertrophic osteoarthritis, arthropathy, and acromegalic features. And there are thyrotoxicosis like thyroid acropathy and jackhammer operators occupational may have clubbing. Clubbing in COPD will never show clubbing. If chronic empyema and bronchitis, they usually don't cause clubbing. The presence of clubbing in patient with COPD should prompt a search for underlying cancer, bronchiectasis, or interstitial lung disease. In lung diseases, clubbing is seen either due to impaired lung function, where prostaglandin E2 destruction by the lung is impaired, or destruction of the pulmonary capillaries result in escape of the megakaryocytes into systemic circulation, or excessive prostaglandin E2 or vascular endothelial growth factor production by the tumors. Coming to unilateral causes of clubbing, there are asymmetrical clubbing usually indicates impaired regional blood flow caused by localized vascular disease or hemiplegia. The causes of unilateral clubbings are hemiplegia, aneurysm of the subclavian artery, bronchocephalic trunk, aortic arch, axillary artery, palmar arc, pre-subclavian coarctation of the aorta, left-sided clubbing is important, Pancoast tumor, unilateral erythromelalgia, a rare neurovascular peripheral pain disorder commonly associated with myeloproliferative disorders, in which blood vessels, usually in the lower extremities, are episodically blocked, then become hyperemic and inflamed. AV fistula, used for hemodialysis, can cause unilateral clubbing infected arterial graft. Coming to some clubbing pearls, drumstick type of clubbing is seen in bronchiectasis, congenital cyanotic heart disease. Parrot beak type of clubbing is seen in bronchogenic carcinoma. Painful clubbing is seen in bronchogenic carcinoma, subacute bacterial endocarditis, lung abscess. Reversible clubbing is seen in lung abscess, empyema thoracis. Unidigital clubbing is hereditary repeated local trauma, median nerve injury, sarcoidosis. Clubbing with cyanosis is seen in cyanotic heart disease, pulmonary AV shunt, pulmonary diseases like lung abscess, bronchiectasis, cystic fibrosis. Acute clubbing, as I have already discussed, that is clubbing within 2 weeks after onset of illness, seen in lung abscess, empyema thoracis. Recurrent clubbing may occur in pregnancy in otherwise healthy females. Differential clubbing is This type of clubbing is limited to upper or lower limbs alone or is often associated with cyanosis. Clubbing limited to upper extremity seen in chronic obstruction of the veins of the upper limbs extremity upper extremity that is seen in IV drug users. Clubbing limited to lower extremity is seen in patent ductus arteriosus with reversal of the shunt that is Eisenmenger PDA and infected abdominal aortic aneurysm. Pseudoclubbing is characterized clinically by asymmetrical involvement of the fingers and radiographically by reabsorption of the terminal tufts, that is acroosteolysis. It is seen in subungual tumor or cyst, subperiosteal bone resorption seen in scleroderma, acromegaly, hyperparathyroidism, leprosy, people working with vinyl chloride. Albert Schweitzer has said, success is not the key to happiness, happiness is the key to success. If you love what you are doing, you will be successful. With this, I conclude my today's topic. Thank you. Keep learning.